Good
Hello.
old. Oh no, recording started. Oh. Helen's done a runner.
She's back.
Can't escape that easily, Helen.
Mm.
Can you be seen?
I don't know. Can you see me?
No, you can't.
Not yet. Okay.
Just keeps.
Hey, you can see.
Anne and Joe.
Thank
Hi.
I'm going.
She's going. Oh, she's leaving us.
See you later.
Do I look all official now?
We'll just wait a few minutes because we're expecting a couple of other Going the Extra Mile winners to join us. And then we'll invite members of the public in and we'll get going properly.
Okay.
You have a good day, Anne?
Busy. But yes, quite busy.
Got one joining us from Cornwall, haven't we?
Yeah, well, I think it was depends on the quality. Helen's on holiday, so it depends on the quality of the internet.
Really?
Sarah, do you want to invite everyone in now? We'll just wait for more members of the public to get going. If you can ask everyone to go on to mute, it will just help with the acoustics on the call with so many people being on.
We'll try.
Okie dokie, we'll get going whilst we hopefully have some other Going the Extra Mile winners with us. So at the start of every board meeting, what we'd like to do is to celebrate some Going the Extra Mile winners. These were mentioned in Glenn's board report last week. So I'm delighted to at least have one, Anne, on the line. I don't think I've got either Helen or Paul on the line, but I will read out their nominations nonetheless. But I will do the nomination first of all for Nicole unit. The Nicole unit was awarded the Winter 2021 Team Going the Extra Mile Award for their consistent dedication to maintaining a very high standard of care despite the COVID pandemic, and for thinking of ways to make the days memorable and special for patients. These are the words of the person who nominated the Nicole Award. Due to visitor restrictions, family members were unable to visit and bring in home comforts. Therefore, the team, represented by Anne today, wrote to companies to ask for donations of DVDs, CDs, personal hygiene products, and treats to make a patient's stay in hospital more comfortable, which they received a huge response from the community for. The nominator provided numerous examples of the Nicole unit going above and beyond to care not only for patients, but also to keep them entertained. The team organised presents, birthday cakes and balloons for the patients in their care on their birthdays. The unit at Christmas organised clear baubles, took photos of patients and placed them inside the photos, not the patients, inside with snowflakes and some chocolate to give to their families. They also helped patients make Valentine's cards for their loved ones. I didn't get any, Anne, and which in some cases were the last gift their families received from them. The team also organised arts and crafts, bingo and sing-alongs. The exceptional care the team provided has been noted and commented on by student nurses, bank staff that help on the wards, and patient families who have written lots of thank you cards to thank the team for their care, empathy and dedication. It's a real shame we can't thank everyone, but Anne, can you go back and say the board's heartfelt thanks for such an enormous level of care given to our patients. So a round of digital applause to the Nicole unit. Okay.
Thank you very much. I certainly will. Thank
you. Now, next up is Helen, who's Helen, if you can turn your video on, that would be great if you're with us. Helen's joining us from Cornwall. Lucky you. I was there a couple of weeks ago, Helen. You've chosen better weather than I did. Helen is our clinical winner for the Winter
I've been very lucky.
Awards. And so I'll just read out the nomination. Helen was chosen after being nominated a staggering 11 times.
Wow.
For exemplary professional and personal support to colleagues throughout the pandemic, her contribution to the Trust's COVID response, and for also going the extra mile in everything she does. One nominator commented how Helen researched developments in the fight against coronavirus even during her days off. This research led to the implementation of Prevalence testing across the Trust, which allowed patients to be safely transferred to the wards appropriate to their clinical needs and prevented the transmission of coronavirus to our most vulnerable patients. A nominator also commented that Helen is an effective team leader whose common sense approach and friendly attitude has gained her respect across all staff and patient groups. This has allowed her to successfully embed policies and processes, to optimise treatments and maintain safety whilst maximising capacity, which was pivotal in developing alongside other clinicians and trust management. Another nominator commented that Helen is a key asset of the Trust, who is extremely thorough and provides excellent quality of care for her patients. So Helen, on behalf of the board, I just want to thank you and again give you a digital round of applause and say we hope you enjoy a bottle of Rattlers cider, which is the hearty recommendation down in Cornwall, and have a lovely break. But thank you very much for your hard work. And then our final, again, the Extra Mile award winner is a non-clinical winner, and that's Paul, who's on the line as well. Paul, I can't see, but I assume you can see us.
Yes, I can.
So Paul is one of our technical managers, and he was nominated for his work ethic and support during the pandemic. The nominator commented how Paul is a joy to work with, as he is always smiling, helpful, has a positive attitude. This is despite the extra requirements the pandemic put on his workload to ensure all the buildings met the enhanced ventilation standards. Work which has been praised across the Trust and in particular by the clinical team. So Paul, on behalf of the board, on behalf of everyone, you are our non-clinical Going the Extra Mile winner. Thank you.
Thank you.
So Helen, Paul, Anne, thank you very much. You're very welcome to join us for the rest of the board. Equally, I will understand if you have other things to do and therefore decide not to join us for the next 592 pages, which is how big the board pack is this week. So, but thank you very, very much on behalf of everyone. See you soon.
Thank you.
Thank you very much for the award and for whoever voted for us. Thank you.
Thank you, Anne. Take care.
Bye-bye.
Bye. So we move on then. We have apologies for absence from Anne Coyle. I don't think we have any other apologies of absence. In terms of declarations of interest, do we have any new declarations of interest? Please raise a digital hand if we do. Okie dokie, so we'll move on then to the last set of minutes. Were everyone happy with the last set of minutes? If you weren't happy with the last set of minutes, could you please raise a digital hand? Okay, I don't have any digital hands being raised there, so I'll duly sign them. So we go then to the action points arising which are on page 19 of the pack. The first was Helen to bring the plan for a third wave. That's on the board agenda, so we'll come back to that later, Helen. Thank you. Then Helen to present year-on-year data relating to the elective incentive scheme onto the dashboard. Again, we'll come back to that. Thank you. Then we had the full DSPT assessment report to be presented today. That's on the agenda. Thank you, Charles. Then we had Helen to bring an update on operational planning and modelling for next year. That's on the agenda. Thank you, Helen. Then Glenn to include an update on IT services within his report. That is done, and we'll come back to that. Then Glenn to keep the board appraised of progress with the CWPS networking meeting or network meeting. Glenn, do you want to say anything on that?
Yeah, I mean, we had a brief discussion earlier with non-exec colleagues, and one of the things we picked up was some continuing concerns, particularly around turnaround times for tests. So I think we agreed that we would also be inviting them through to one of our subcommittees, whether it's clinical governance or finance and performance, just to understand those issues and what the remedies are. But otherwise, we haven't had a network meeting since we last met. Helen's had an operational meeting with the network and discussed some of these issues with them.
Okay, thank you, Glenn. And then moving on, we had the trust-wide oversight of work streams, risks and mitigations be held every 6 months at a board workshop. That will be done. And the Black Swans event training to be organised at the next risk management training. That will be done as well. Then on the integrated performance dashboard, Fiona to include mental health information for children and adults within future reports. Fiona, I'd like you to talk, and I'm sure Glenn will anyway, on the real challenge we have with children or adolescents in crisis at the moment, which is a major issue for our system. And then Helen to ensure the missed opportunity audit be brought back to the board in June. That will be included in your bed modelling work, Helen, so we'll come back to that. And then Helen to ensure the point prevalence survey outcomes be brought back to the board meeting in either July or August. So we look forward to that. Just for members of the public, the point prevalence exercise is a really interesting exercise, which at a point of time calculates what the costs or cost savings would be to the whole system if patients were receiving their care in the right setting for them, given the blockages that occur. That normally runs into millions of pounds of potential savings. I think this time what we're also trying to look at, though, is what the further savings would be if we were able to do more technology-based hospital at home. That's a second level of saving. And a third level of saving would be if we're able to do more prevention work to help people be more mobile and healthier for longer, which again would save the system money. So a really important piece of work, that point prevalence exercise. So thank you. Then the executive team on the monthly safe staffing report to ensure that non-clinical staff be reviewed on a quarterly basis where staff challenges are prevalent. That's ongoing, so thank you for that. Then we said goodbye to Anne last month. Anne Pope, our long-serving HR director. And so Gertie, welcome to you as your first full board meeting today. Anne was going to include some data within the report around recruitment figures by gender profile and disability profile. So we'll do that next month. Then Charles to bring back the medical revalidation report in November. Look forward to that, Charles. Thank you. And then now Gertie to invite 2 members of the BAME network to be allocated places on the National Res Expert Programme to attend a future board meeting, and we're looking forward to that. On the problems of hot days where you leave the door open, if you do have people walking in behind you, dogs barking, I apologise for that in advance. And then just continuing to go down, Fiona to ensure an update on the recommendations following the Ockenden review of maternity services be brought back in August, so we're looking forward to that. Again, the Ockenden work around maternity is incredibly important. We're blessed because of the hard work of Fiona, Sarah and other colleagues to have a very good maternity service in South Warwickshire, but that doesn't mean we can't improve, and that work on Ockenden is part of that. Then Kim to bring the second half of the financial plan once those details have been confirmed. That will come back around September, so thank you, Kim. And then Sue Pike, our Freedom to Speak Up guardian, to ensure that registered nurses and midwives be broken down analytically into two separate groups within the Who Was Speaking Up by Profession graph. And that will come back to us in September. So I think they were all the matters arising. If you think I've missed a matters arising, could you please raise a digital hand? Okay, so we'll move on. As I mentioned, today is an exceptionally big board pack. I'd just like to put on record my thanks to the executives in producing such a voluminous tome. I know it only occurs once a year to be this size, but thank you, and thank you to your teams. Also to the non-execs for their diligence in making sure they absorb all of that to make the board meeting function. But I will keep the pace going because it is a lot of work to get through. So the first is the annual accounts. Kim?
Thank you, Chair. So the annual accounts were presented to the Audit Committee that was held this morning. Previously, the Audit Committee received a set of draft accounts. You'll see in Appendix 1 a list of changes in terms of the notes to the accounts. And the Audit Committee have obviously gone through some of the changes since the draft version. The key points to note is that we outturn the year with a surplus of group consolidated surplus of £400,000 and a strong cash position of £44 million for the cash balance for the year end. The key things to note for the accounts is that it reflects the recognition of PPE and stock that was consumed in the year that we were asked to consolidate into our individual trust positions towards the end of the year by the Department of Health. It also reflects the increase in the valuation percent on shares and also impairment of our assets of 3.9 million in relation to the modern equivalent asset valuation. We also received the ISA 260 report from the auditors this morning, which is effectively the audit report on the accounts. They highlighted that they received good set of working papers and worked well with the teams. The audit is largely complete and there are no material misstatements, and therefore they are going to be issuing a modified audit opinion. The board is being asked to approve the accounts for submission to the Department of Health. I won't go through every single page of all the accounts for the board.
That's great, Kim. Thank you. Just because I know it's been subject to an audit committee discussion as well this morning. Rosemary, as chair of the audit committee, is there anything you'd like to add?
No, I think I think the key point is that the auditors have a few little points just to tie up, but they will be issuing what they call an unmodified opinion on the accounts, and the accounts will be filed by the 15th of June deadline. So nothing more to add. Just to say that their value for money work is still ongoing because the deadline for that is now September. However, again, they've done sufficient work for that if there were any concerns, they would have raised them now, and they do not have any concerns.
That's great. Thank you, Rosemary. So any questions or perspectives, Glenn?
Yeah, just wanted to thank Kim and her team for pulling together a good set of accounts. I mean, the audit committee, as Rosemary said, was very straightforward this morning. And actually, alongside this, I described the strange financial regime we operate in later in my chief exec's report. But we were actually given permission to have a small deficit this year, but that didn't seem to fit in with our decade of surpluses. So to get the right side of the line, despite what was a really strange financial regime last year. Was credit to everyone, but thanks to Kim's team for pulling it together.
No, thank you, Glenn. And it's worthwhile remembering some members of the public might wonder why we are able to make a surplus and other trusts around us are unable. If you do an analysis, and Glenn and I looked at it yesterday, comparing the cost effectiveness of trusts around the country, SWFT is in the most efficient of trusts around the country in terms of costs of delivery. And that's why we're able to make a surplus. And it is a quite extraordinary testimony to the quality of the executive leadership here that we've been able to do that for over a decade. So well done, team. So we have to approve this. If you're not happy to approve these accounts, would you please raise your digital hand? Okay, duly approved. Thank you, Kim. Thank you, everyone involved. We then move on to the annual governance statement, and I'll try and help members of the public. That's on around page 88 of the pack. Glenn?
So, as is customary, I attended Audit Committee this morning to go through the annual governance statement. I just wanted to bring to your attention a couple of changes that I agreed with the committee. So firstly, on page 91 of 587 of the pack, or page 4 of 16, depending on which numbering system you're looking at, the very last bullet point on that page describes it as if it's present tense. That the urology waiting list problem, it should be described as past tense, so it should say this created a risk and this impacted on the RTT position. So that was that one. And then also then on page 93 of 587, there's a reference here to the work of the improvement board, which is paragraph 2. It should say in that sentence, an improvement board to oversee programs, stroke projects, and manage associated risks. So it's not our risk committee, but it's the risk of those projects for improvement. But those were the only two changes that we agreed. Otherwise, the statement was accepted. And so I recommend it to the board for approval.
Thank you, Glenn. Thank you for those clarifications. Any questions on the annual governance statement? Please raise a digital hand. Okay, if you're not happy to approve these, please raise a digital hand. Duly approved. Thank you very much. We'll then move to the Data Security and Protection Toolkit assessment, which is on page 104, 587. Charles?
Yes, I think you can see a reassuring picture here that the Trust has made good progress in achieving the standards required. There are 6 standards that are still not met, but there is action plan, and we believe that they will be met by the time we actually have to submit a report on the 30th of June. The one of those which I think has a small amount of risk attached to it, which is always a problem at this time of year, is the 95% compliance of staff with the information governance training. And this has been moved on to an IT system, which isn't the easiest to access. This is a national requirement, but we're working very hard to get that compliance, and putting on some extra classroom type training to do that. But I think this is very important in general, that we achieve these standards, particularly with the rise in threats from cybersecurity. So a lot of work's been done here.
Thank you, Charles. Any questions from colleagues on the DSPT assessment? Okay, colleagues happy to approve? If you're not happy, please raise a digital hand. Duly approved. Thank you, Charles, for your oversight on that. So we move on then to the performance review and assurance part of the pack, and the Chief Executive's report, which is on page 108. Glenn.
Thank you, Russell. So quite a long report this month, so I'm not going to go through all of it. Indeed, Chairman, you went through some of it earlier, which I will come back to. So just some highlights from it. Firstly, I agreed to come back on the IT business case update, which was actually an answer to a question that we posed at the end of the last board meeting. Just to make it really clear that our intention here is to retain a first-class NHS IT service, and we believe that the best way to do that is the way that we've described, which is to put the two services from the George Eliot Trust and from SWFT into the arm's length company, and to invest more in IT as a consequence of reinvesting the savings that come out of it. We are in a dispute process, and Chairman, you'll be meeting with the unions later on this week in order to hear that. I then provide an update on Ellen Badger Hospital, which we still have a situation where the League of Friends are suggesting that they will seek to take back the funding that they gave us to start the phase 1 project. That's a difficult position which we will try to navigate our way around with them, but we also provide here an update on the review of inpatient facilities. And board colleagues will remember one of the reasons why we couldn't move forward with the full project was because we're waiting to see what the bed requirements will be across the county in those kinds of facilities, and that review needs to be completed before we could do that. Then we refer to a trust strategy and place plan. This is the board meeting where we normally review strategy, but later on in the confidential section, we've got a first look at a draft place plan, which is going through the process of being signed off by partners, and very much look forward to bringing that through to a public board meeting soon. But it's a really excellent strategy that takes forward our helping you to help yourself approach. I then talk about the accelerator program, which I won't talk about because Helen will probably want to talk about that later. Digital innovation, there is an appendix there of a newsletter which sets out what we're aiming to do in the Stratford on Avon Hospital Digital Hub. I've also sent to board members an update of some of the projects that are underway, which is really quite exciting. And again, those are things we'll see a lot more of. There's then a section called Clearing the Financial Fog, which is an old accountant's view of the way that the NHS has lost its way a little bit on control of its finances. And I and others are working with the national team to try and get a more balanced approach from the second half of this year moving forward, particularly get that balance right between incentives to operate effectively, but also having to operate at a system level. I won't read through everything, but the developing a place-based financial strategy section talks about left shift, which is what Chairman described at the start of the meeting, the notion that we can deliver care in lower cost, but actually better for the patient settings, particularly the shift from hospital to out of hospital. So we will be doing a further point prevalence study across the whole Coventry and Warwickshire system, which will identify the potential to shift activity today into those settings if we had capacity, but also to look at prevention and technology-enabled discharge also. And then two final things. I give an update on the system review with NHS England and NHS Improvement. I draw to your attention, there is still a £3.3 million unmitigated deficit against the H1 plan, the first half of this year. There's a meeting at the Finance Advisory Board of the system to discuss that later on this week, and Kim and I will be getting our heads together on that, I think, tomorrow. And then finally, another example, a great team that innovated during COVID with a little bit of an insight into our podiatry service. That's all I wanted to highlight, Chairman. Happy to take questions.
Thank you, Glenn. Very comprehensive report. There's clearly a lot going on, and thank you for your leadership. Questions or perspectives to Glenn? Please raise a digital hand. Simon?
Thank you, Russell. I've got two observations and a question, really. So, a bit like you, Russell, you said if ever anybody wanted to see how strong the agenda to change is in the NHS at the moment, you've only got to read this report, really. Last week, I went and looked at the digital hub in the flesh for the first time, and I was very impressed with what I saw. There's a lot of very good kit there, but most importantly, I think I'm very impressed with the things we're trying to do with it. So I would applaud the use of that service. I think it's very good. And Glenn, you talked about financial fog. Is it foggy enough to see whether we've got a sympathetic ear or not to what you're trying to say?
So, in answer to that question, yes, I think so. I think we've got a really good national finance director of the NHS, and the good thing about him is he does listen and engage, and we've been having meetings with him every few weeks, me and a few other like-minded chief executives, it says in the report, and he absolutely gets the issue that we raise, which is you need a connection between, you need some sort of incentive, particularly for clinicians, to deliver the levels of productivity that we'll talk about later in our finance report. And that doesn't come from a situation where resources are taken off trusts if they create surpluses and given to trusts if they create deficits. We have to have something that's a bit more judgmental than that. So that's the sympathetic ear that we're getting. Obviously, he doesn't want to hear about the moans, he wants to hear about solutions. So we have suggested some ways that we could resolve that, and we'll see whether those are incorporated into the H2 plan.
Thank you, Glenn. Thank you, Simon. And then finally, Jeff, and then we'll move on.
Yeah, perspective. Thanks for the report, Glenn, which is fantastic. And as Simon says, so much going on. As it emerges around the point prevalence work and situations where people will be treated are changing as a result of technology and so on and so forth, I would absolutely urge the overuse in some regards of the communications department here. Because one of the big problems with any change is people not understanding why, how and when. And it's the why often that gets a little bit forgotten. And it is a difficult thing to do, to change people's habits of a lifetime when they've been used to knocking on the door of a GP and seeing, as my old dad did, Dr. Trimmer, who died in 1952, and my father was still looking for him in 1968. So that change piece is massive. And I think particularly at the moment, as people are very sensitive around, post-COVID and getting back to inverted commas normal, that need for communications is ever more acute. No pun intended.
No, thank you.
Yeah, I mean, just to add to that, I absolutely agree with you, and it's been fundamental in our strategy. That the notion that a bed actually makes people better is one of the things that I'm really keen to get people to understand, that a bed is something that people wait in hospital. So our approach will be delivering care into patients' homes, into the places they call home, rather than seeing the commodity of a hospital of beds. It has to be about the physical assets and the skills, and they can be delivered anywhere.
So important. The badger is so important.
Yeah. But also the key importance of safety. That it's inappropriate to us to invest in beds unless we're able to provide safe services into those beds. Okay, we'll move on then to the Integrated Performance Dashboard. Thank you, Helen, for standing in for Anne. Over to you.
That's all right, and thank you, Chair. And this is a much more lengthier introduction than I probably than you're used to from me, because this is Anne's words. So as Managing Director, she wanted to pull out a number of key issues from within the Integrated Performance Dashboard. I think it is fair to say that the commentary within the dashboard has evolved this month, and I think that reflects many of the exec directors now wanting to move into a business as usual and reflect some of the COVID recovery within the report. And so you will see updates against shadow operational standards, elective recovery, the accelerator scheme, and some productivity and efficiency measures. I think it's fair to say that it's probably time to review the Integrated Performance Dashboard, but we are waiting until the issue of the NHS oversight framework, which we're expecting in the summer, and then we'll review the dashboard. I think the intention to do that is across the group as well, isn't it, Glenn, to reflect the new oversight framework. So the key points from the exec directors within the Director of Nursing's commentary this month, additional consideration has been given to feedback through the I Want Great Care scheme, where patients are leaving hospital without their respect forms. And also there's a focus on, as you've mentioned already, Russell, the focus and the increase that we've seen of children and young people attending the hospital in a mental health crisis, and there's some really great work that Fiona's been doing that I know she'll want to highlight within her report. Within the Director of Ops commentary, you'll see detailed the rapid increase in A&E activity during April, and also how we've counteracted that by the positive impact of ambulatory same-day emergency care, having having an impact on our length of stay. Cancer performance, as we're all aware, still remains a focus, and there has been some strong recovery in March, and I'll discuss that further when I get to my section of the report. And also detailed in there is the elective recovery and the target of 70% for April, which was delivered. And as you can imagine, significant work has occurred over the last couple of months across the system to be successful in the bid for the Accelerator scheme to deliver 120% of recovery by the end of July. And again, I'll go into more detail with that later. The out-of-hospital teams have delivered significant improvements against the 2-hour urgent response target. And as we know, each system has been allocated resource during this year to support system capacity and infrastructure to deliver an urgent community response across the system and deliver the standard. And so we're working collaboratively with our partners across the system to do that. The Director of HR's commentary is noteworthy, as in March we've seen continuous improvement in reduction of the sickness absence rate, and I think it's fair to say that with a rate of 3.43% is the lowest rate of sickness that we've recorded in the past 5 years, which is a tremendous achievement given where we've been in the last 12 months. And at month 1, the Director of Finance notes slippage on the cost and in productivity improvement plans, reporting on productivity and efficiency measures as a positive addition to the Director of Finance's commentary. Just take any questions on that, Chair.
Thank you, Helen. Any questions, or should we dive into the detail, team? Okay, we'll dive into the detail. Just because of the length of the pack, if I can ask executive directors just to pull out the sort of key points that they want, and obviously take the report as read. So Fiona, first of all, you.
Yeah, thank you. So I'll concentrate, bearing in mind that that commentary just on the children and adolescent mental health section of my report. So as my commentary says, we've had a significant increase in children presenting with psychological and mental health crisis into Warwick Hospital, as well as UHCW in terms of the system. That's moved from on average last year 1 to 2 people, children, inpatients, and potentially staying up to 7 days as an average, to a maximum of 12 patients in McGregor ward at any one time, the longest length of stay being 50 days. So a significant increase. It's also increased, that has come with associated staff risks, patient risks, financial and cost risk and performance risk to us as an organisation. So when we recognised that that wasn't just a very short-term increase, we raised to our system colleagues that we needed and suggested that they put together a response similar to a pandemic response in terms of major incident, and recognise that this is an epidemic that we're seeing nationally and locally. And so the CCG took that suggestion and have put a gold, silver and bronze approach into system. So there's a daily bronze, there's a twice weekly silver, and there's a once weekly gold command, where so that any particular issues hopefully can be operationally managed at bronze, but then escalated through if need be. That has seen some benefit to us. So at the peak, as I said, we had 12 individuals in McGregor ward. This week we've had a maximum of 5, so that's sort of very much improved in the last 2 weeks. The other things that have helped that, I guess, that have been put in is better communication and better coordination between local authority, the mental health trust and CCG, and the acute providers. And so that regular daily conversation about the individual patients and what care they need, and finding that package of care between those providers has helped to unpick some of the issues. About a third of those patients have been waiting for Tier 4 beds, which, as you know, are commissioned and provided by commissioned by NHSE. And again, that is a national shortage of bed capacity there. So one of the 4 individuals that we have currently in McGregor is waiting for that, and they tend to be the longest wait to stay. But the others, the particular reason I said it's mental health and psychological crisis is because it's not always mental health services they need. They do often need social care. And I'd say another third, a third is Tier 4, a third is probably local authority, and a third is lower level mental health services, I'd suggest. So that better coordination, that better communication is helping. CWPT and local authority have increased their capacity, particularly at weekends, but also at week as well. We've increased our staffing, which has put an additional cost to us, but that's the only safe way we can do that at the moment. So we are incurring those specialing costs, but we have put a proposal to the system to help fund that. We've done individual risk assessments on the patients, but also on our service, and we're currently going through a gap analysis and assessment of risk against CQC standards. The other thing that we've done locally is increase the staff training and the wellbeing offered to staff, because there is a considerable psychological stress on the staff as well as the patients in that environment. But other than that, I think that covers all the mitigation, most of the mitigating actions that we've put in. It has an improved picture, but hasn't definitely not gone away, and we're monitoring it closely.
Thank you, Fiona, and thank you for raising it. This is a desperately sad situation for adolescents just starting their life, being in such situations of trauma and self-harm. So this is a real challenge to the system. But on the rest of Fiona's report, any questions or perspectives? Okay, thank you, Fiona. Please continue to keep us briefed on the issue. So Helen, over to you.
Thank you, Chair. I just wanted to highlight 2 particular issues, and then I'll just take questions on the rest of the report, if that's okay with you. So, as we know, we have struggled with the maintenance and delivery of the cancer targets over the last year during the COVID period, and it was fair to say that there was some struggling to meet those targets pre-COVID. What I am reporting today for April's data that there has been a strong recovery with the 14-day or the 2-week wait delivering 92.5% against the 93% target. And as you can see detailed in the report is the achievement or the challenges that we have against some key specialties within cancer. The 62-day cancer is again shown some strong recovery, and whilst it isn't hitting the target, we're at 72.4%, which I think has been the highest that we've seen in a number of months now against an 85% target. So again, some recovery in detail within the report. It also sets out that we've seen a huge reduction in the patients that are waiting over 104 days, and over the year that's reduced considerably. I think it's fair to say that there's been an awful lot of work ongoing in the last couple of months as we've started to come out of COVID in terms of supporting that recovery. So we've got a number of specialties that are significantly challenged that we're putting some focus pieces of work around. So that's gynecology, ENT, breast, upper and lower GI and urology, and there are delivery plans in place for each one of those specialties. The non-exec Finance and Performance Committee yesterday saw a presentation to try and give assurance to the non-exec directors around our progress around cancer, and we also did a mapping exercise of our pre-COVID delivery of the standards during COVID and then as we've come out of COVID, and I think the performance data looks very, very promising in relation to cancer. We know at some point that the 2-week wait will probably go to be replaced by the 28-day faster diagnosis standard, and we are monitoring that in shadow form. And the standard for that is 70%, and we're at 68%. And I think that is a less challenging target for us to deliver, where the challenge for us quite often in the 2-week wait is that the amount of referrals that we are seeing, particularly in breast and breast symptomatic, because they all come in on a 2-week pathway. So I think that's where we are with cancer, but there has been significant work moving forward, and I feel much more assured that there is some real grip on cancer. What we have done also is put some additional senior project support within cancer to support the cancer manager and the general managers and the consultants to be able to pull their plans together and make sure that each of those projects is on track and delivering as set out in the scope. And we also have a twice weekly senior meeting with the leads across the divisions for cancer to make sure that each one of those plans remains on track and that we can pick any issues up as they arise. The second thing I just wanted to talk about, because we probably haven't talked about it in detail here, is the elective recovery target, and also the accelerator bid. So you'll all be aware that we were successful across the system for the accelerator bid to achieve 120% of recovery by the end of July. At some point I thought that was a good idea. I don't know why I thought that was a good idea given the amount of work it is, but actually it's the right thing to do to be able to recover our position as quickly as possible. And so what you will see in the summary page on elective recovery is April's performance against the original elective recovery target, which was 70%. So we easily achieved the normal elective recovery target. As we move forward now, we have an overperformance trajectory now to get us to 120% by the end of July. There are significant plans in place across the system and a governance structure and plans for each of those specialties. And I shared that with the non-exec directors yesterday around the monitoring tool that we are using to increase our productivity and efficiency across as many specialties as we can to deliver the ask, but also so that we are not exhausting our already tired and fragile staff that are just recovering from COVID. And these staff have to deliver cancer and the elective recovery. It's the same staff that are delivering this. So we just need to be mindful that we put their well-being at the centre of this. But some of the work that we are doing is looking at some of the GERF methodology around productivity and trying to weave some of that within our productivity and efficiency gains across the organisation. We've also appointed 2 fixed-term associate medical director posts that are working very closely within the division across the divisions to support the programme and also COVID recovery, to making sure that all of our recovery plans are COVID secure. In the report at the time of writing this report, I said that May's position looked challenging. And I can report hot off the press that we have delivered the mains target as well, both in terms of activity and finance. So from a SWFT point of view, we've delivered April and May, which is very reassuring. It will be challenging as we start to move forward, where the recovery trajectories for June are 110% and 120% for July. We've also developed across the system a suite of productivity measures that sit alongside this piece of work, so we can demonstrate how we are doing more with what we've got, rather than putting additional significant additional resource in, because that's what makes the programme sustainable. And my intention is to pull those out that are already within the dashboard that we have, to be able to demonstrate improvement. Things like our theatre utilisation, our DNA rates, our outpatient utilisation, cancelled operations, virtual outpatients, and length of stay, and some emergency activity measures as well, so that we can demonstrate we're creating the right capacity within the organisation to deliver the elective recovery scheme. And I'll take questions now then, thank you.
Thank you, Helen. Any questions or perspectives to Helen? Rosemary?
Thanks, Helen. That was a great cover, particularly good news in terms of the work being done on cancer and on the elective recovery. One area of concern is the growth in the A&E activity, and I just wondered whether you could share with us a little bit about where you, both at a local level and at systems level, things are being addressed sort of to prevent this figure going up and up.
Helen, just before you reply, I am conscious of the fact we're barely a fifth of the way through the board report, so if I can ask for short questions and short replies, please.
Okay, so that's actually in my capacity planning report, Rosemary, so shall I cover it there?
Okay, yeah, happy with that, yeah.
Thank you, Helen. And any other questions or perspectives? Okay, if I can ask executives to pick up the pace, please. Gertie, welcome, over to you.
Thank you, Chair. I'll be very brief. You can see recruitment continues positively, and alongside recruitment, the work in education to start developing our own workforce with a registered nurse degree apprentices starting this in May, which is really positive. Sickness, Helen has already covered. The first time in 5 years we've achieved that low level, and you can see areas of notable reduction being women's and children's and out of hospital, and both Helen and Fiona have talked about the need to ongoing support for colleagues and staff as we move out of COVID and into business as usual recovery, which continues. The vaccination hub closed on the 27th of May, a fantastic piece of work to support our colleagues across health and social care, with over 15,000 vaccines being delivered. And we will start to see feedback into other committees and to board of the People Pulse from September onwards, which is a more regular feedback loop than the National Annual Staff Survey. And I'll finally finish with the big conversations, which is just of note because it's a really positive piece of system work in terms of developing our leadership community moving forward. I think I've done it there, Chair. Happy to take any questions in less than a minute.
Thank you, Gertie. Fantastic. Any questions or perspectives to Gertie? Is that a legacy hand, Rosemary? Thank you. Thank you for your succinctness, Gertie. Great to have you on board. And Kim, really like the new look at the finance report. What would you like to pull out?
Thank you, Russell. Gertie set the precedent now to talk fast. I'm not sure if I can do this. Okay, so month one reporting is to show a small deficit of just over £100,000, but a big caveat is that that doesn't include a recognition of the income in respect to the elective recovery fund that Helen's alluded to. We've obviously will only get a share of that money if we all deliver at a system level. So and obviously the numbers that we've got are preliminary numbers against a preliminary draft baseline, but obviously those are the target numbers that we're working on achieving. Key things to bring out is that we are still continuing to work with the divisions in terms of the cost improvement programme. You know, we've done a lot more work on productivity, as you will see in the reports highlighted. Internally, credit really to the team, we've developed our own in-house weighted activity unit so that we can actually compare our performance on a month-by-month basis, and we've obviously retrospectively done that for going back another year so that we can actually see really how we're doing. And I suppose it's really obvious really where we're getting back in terms of the productivity, in terms of driving our costs down and still delivering on the productivity. So that's a really positive thing. We also produced some new bubbles, which we shared at F&P yesterday. I couldn't bask in their glory, but they shared those at F&P yesterday. And that's focused on our cost base, so you can really see, I suppose, where there are opportunities by division. So the next piece of work is obviously to engage in the divisions to drive those productivity savings at the divisional level. Our cash remains strong at £40 million. I've also included an update on debtors and creditors in terms of performance, and you will see over the year the real big impact and drive really that the department's been focusing on in terms of reducing the amount of debtors and creditors. So they exclude obviously accruals, etc. But again, positive performance there. We are developing the report as we go, so there will be more things added, I think, each month as we sort of refine our reporting and capturing of information behind the scenes. But happy to take questions.
Great, thank you. Really good to see the stuff on productivity in the WAU coming through. Thank you, Kim. Glenn?
Yeah, it's great to see the increased content and the as you say, the productivity indicators. I just wanted to dwell on those a little bit, Chairman. I realise we haven't got much time, but we discussed this yesterday at the George Eliot board also. So that weighted activity unit is a really important measure of productivity, and it's great to see it real time. The last time that was published nationally, if you look at the comparative cost for SWFT, if we operated at the national average cost of delivery, we would be £25 million more expensive, which shows how our productivity is going. But we're starting to look at this across the ICS now. And what that shows, firstly, is at George Eliot, yesterday we looked at this, George Eliot could save £5.2 million if they operated at that standard operating cost. And indeed, they're probably, based on some of the work we've already done, probably heading towards that, and I think that's doable. The UHCW comparative figure is if UHCW operated at that standard operating cost, they would save £83.7 million, which is quite a staggering opportunity. Now, some of that will be in their PFI, but I think they talk about 20 million or so in that. So there's potentially £63 million worth of system productivity improvements that we can either try and achieve or try and understand why there is that discrepancy. But it's a really good thing to be able to look at real time.
No, fantastic and very important. Kim, I'm conscious I lose Fiona in just a minute for another meeting.
Oh, right, okay. No, that's fine.
If there's nothing else, I'd like to pass over the mortality trust-wide report, which I'll come back to, Charles, and just pick up the monthly safe staffing report. Fiona?
Yeah, thanks, Chair. So apologies, I have to dip out for a little while. So this is our standard safe staffing report. There's nothing extraordinary in there other than it has got turned into a overstaffed position, mainly being driven by the paediatric issue that I've already alluded to, and the additional staffing that we're having to put in to keep those mental health patients safe. But otherwise, happy to take questions.
That's the type of introduction to a report I like on a day like today. We've got 592 pages. Any questions to Fiona? Sue?
Yes, Fiona, just to thank you for including the theatre staffing challenges in some detail. And it's obviously an area where there's a lot of activity, and it's also a long-term hotspot. So just to ask if we could continue to see the trends in those in the next few months, please.
Yeah, my intention, Sue, there's been some new Royal College of Nursing guidance on safe staffing, or standards on safe staffing. We cover most of it, but the only gap really was that if there is a 30% vacancy position in any area, it should be reported to board. So that was the trigger for that, as well as some of the conversation we've previously had. Yeah.
Excellent, thank you.
Thank you, Fiona, and thank you for your hard work. And we know you need to rush off. So thank you. So going back then, Kim, was there anything else you wanted to add to your report? I did stop you in your prime just to give.
Sorry, yeah, it's just to say that there's been some work at a system level, working with NHSI around capturing all the right care analysis as well as the model system information, and it's being reviewed at a system level at FAB on Friday. So we will be challenging each other's organisations around what more we could be doing. So I just wanted to say that.
Well, given some of the numbers that are involved in other bits of the system, I'd love to be a fly on the wall in that discussion, Kim. So moving on then to the mortality report. Charles, anything you particularly like to pull out?
No, I mean, again, this is showing our mortality indicators are within the control limits, and there's nothing I would like to sort of add today.
Okay, great. Thank you, Charles. Sue, I assume that's a legacy hand from you. Any questions to Charles on the mortality report? Okay, thank you, Charles. So we'll move on then to the Audit Committee report for 19th of May. And again, if I can just ask people to be rapid, we're running quite behind now.
Yeah, and Russell Reid, I think all the points that I would want to bring out in this report have already been covered by Kim. The meeting covered the early review of the accounts, and again, obviously, we met this morning to finalise our review and to recommend the accounts for approval, which has now been duly done. So happy to take any questions.
Thank you, Rosemary. Any questions to Rosemary? Okay, thank you, Rosemary. Then we've had the Joint Audit Committee and Clinical Governance Committee assurance statement. Rosemary and Bruce, anything you particularly like to pull out, or should we take as read?
Not from my perspective. This is really to give the board assurance for the purposes of the annual reporting that all aspects of governance are covered between the two committees.
Super, thank you. Very assuring statement. Any questions from colleagues? Okay, thank you, Bruce and Rosemary, for putting that together. And then we're on to the clinical governance report for the 12th of May. Bruce, anything you particularly like to emphasise here?
Yes, there's a few points. Thank you, Chair. So there's 3 points within that report where IT and Chief Technology Officer is referenced for both electronic respect forms, for the IT system for mortality reviews from Wye Valley, and for the governance package around LOCSIPs, the Local Safety Standards for Invasive Procedures. I'm pleased to say that I've had the conversation with the Chief Technology Officer, and it's good news on all three. They're progressing well. There are some system discussions to get the respect form spread, but that's not particularly an IT issue. Fiona has already made the mental health McGregor problem apparent. So any questions? Happy to take them.
Thank you very much, Bruce. Any questions to Bruce on the Clinical Governance Committee report for the 12th of May? Okay, thank you. Then keeping the pace going, the F&P from the 4th of May. Simon?
Okay, well, the 4th of May, Chair, is a written report that I following up the verbal report at the last meeting. So the verbal report for this meet is yesterday's meeting, and probably 3 things to tease out. One is just to affirm that the accelerator bid, it really is very strongly gripped at the management level, very assuring. In terms of cancer, a whole host of small process changes are identified that could add up to some quite significant improvement in the way we're reporting cancer, which is encouraging. And some really strong work around productivity, especially the bubbles Kim reported on, because they benchmark us against other peer organisations, which is encouraging. And I think it's just worth saying here that what has been done on productivity in this organisation is a little bit of a hidden secret, and I've encouraged Kim and Helen to make it less of a hidden secret, because I think it really is worth understanding more. And there's also some good work about sharing best practice across the group in terms of productivity from within SWFT as well. So happy to take questions.
Thank you, Simon. Any questions or perspectives? I'd endorse the comments about productivity and hiding our light under a bushel. Okay, super. So we'll move on then to the Foundation Group Strategy Subcommittee report for the 18th of May. Chris, is there anything you'd like to add to this?
Just two very quick points. We had a really good presentation from Wire Valley, which links back to the comment that Simon's just made. But one of the risks that it did highlight was around the analytical resources required within each of the trusts. So I just wanted to highlight that as an issue in terms of productivity generally. And then the only other point that I wanted to highlight was there was a discussion around having associate members. So a conversation about Worcestershire Acute being a member of the Foundation Group as an associate, which I think is a really positive move forward in terms of learning from yet another trust.
Super, thank you, Chris. Any questions or perspectives to Chris? Really exciting, the sort of potential developments for the Foundation Group, sharing our experience and learning from others. So keep us briefed on all of that, please, Chris. Okay, so we're then on to the operational capacity plan and winter plan for the year past. It says 2020-21, so 21-22. So Helen, what would you like to put out as the key points here? Because I know there's an awful lot of work here, but if we can recognise the time constraints.
Yeah, no, absolutely. Russell, I would normally do this in a workshop, but we've been unable to bring it in a timely way here. So I set some of the challenges out here within this paper. So a couple of things I just wanted to pull out is that within the paper there is also the capacity modelling for the next 5 years, and you often see this here. And a do nothing scenario says we will need 81 additional beds, mainly in medicine, if we don't do anything differently in terms of managing demand or managing access or doing things differently. So with that in mind, the paper contains the missed opportunities audit, which to respond to the earlier comment. And this is what all organisations in the system have had one of these audits, and they're very, very similar in terms of the recommendations. And so this is the piece of work, Rosemary, that says what we're doing across the system to be able to deliver some of the changes that are required around emergency demand. Further on in the paper is detailed the challenge that there is for us as a COVID wave and a winter plan for this year. And as many years we've seen, it is a significant challenge for us, being around about 100 bed challenge. So rather than put additional beds in, which we never really like to do, this paper sets out the schemes so far in delivering that 100 bed ask. And there are more schemes that we identified. So we met on Friday to go through the divisions where they've had time to think about that. And Jit and I met this morning just to start scoping those out. So there is a project structure around this that will meet in 2 weeks to make sure every single scheme has a good governance around it, so that we can start identifying the bed savings and the flow improvements across the organisation. And I'll just bring it back as I would normally do in terms of an update to board.
Thank you, Helen. I mean, really impressive piece of analysis and great to see the learnings. And any questions or perspectives from colleagues? I think the worry, and it goes back to what we were talking about earlier for me, is the issue of adolescent. We call them paediatric beds, but it's including adolescents, anyone under the age of 18, and the way that develops. But I know you'll be looking at that very closely as well. Sue, you raised your hand.
Yes, I just wanted to ask about theatre capacity, because there's ongoing work needed there, and I just wondered when the theatre plan for winter would be clear.
So part of that, Sue, was we have a stranded theatre at the moment because of our COVID pathways. So that's hoping to be released within the next week to 10 days, I think it is, isn't it, Sophie? Which gives us a big chunk of our capacity back. We then just need to map through in terms, have we lost any of that utilisation, that capacity? But our utilisation and our productivity is high at the moment. So there may not be a significant gap, but we're just working through that. One of the AMDs who was appointed to support this at interview said one of his objectives is to not stop anything or close anything through winter. He hadn't seen the size of the challenge as yet, so I took that objective. I think he is now regretting saying that will be his objective for the post, but I feel really confident that we've got plans in place that if we needed to surge from an ITU point of view, then that won't be into theatre, so we will be able to continue to manage our emergency and elective surgical capacity throughout the winter period, unless it was a surge that was similar to what we saw over December and January this year.
Thank you, Helen. Thank you, Sue. And again, just conscious of time, finally, Chris.
Thanks, Helen. Really good report. I just wanted to get some reassurance from you that you were confident that other players within the system understood their role within this, particularly as we move towards winter. There's a whole range of partners and different providers that we are reliant on. So how confident are you that they really understand the issue?
I think during COVID, Chris, our relationship with our partners has been very, very strong, and we've continued to foster that relationship. So a number of the work streams that will feed into the System A&E Delivery Board, particularly around discharges, around living well, end-of-life care, and also the conversations that we'll be having with YMAS and also our other partners, will all be taken through then. It does feel very, very different this year in terms of that engagement than it has done in previous years. So I feel very confident about the plan for this year.
Thanks, Helen. Thank you.
Okay, so we had one really tough objective, doesn't want to close anything. We've just had another very strong statement. I'm feeling really confident. So we look forward to winter with less trepidation in our heart. Thank you, Helen, for your hard work. We then move on to summary of ratified policies. Helen, anything you particularly want to pull out here?
No, I just take questions.
Okay, thank you, Helen. Any questions on the summary of ratified policies? Then we've got the summary of reports for noting and information. No, I think that's, sorry, I apologise. We have the updated register. I apologise for a second. In my board report, it shows the Senior Information Risk Officer Annual Report, which isn't on my agenda. So, Helen?
Yeah, thank you. Russ, I don't intend to say anything. I'll take it as read and take questions. It's a short report, so I'm sure it's quite explanatory.
Okay, thank you, Helen. Any questions on the SIRO annual report? Okie dokie, and then I think we move on to the updated register of directors' interests. Sarah?
Thanks, Russell. I'm happy to take the report as read. Thank you.
Okay, everyone happy with the accuracy of this? Otherwise, forever hold your peace. Please raise a digital hand if you've got an issue. Okay, super, thank you. So we'll move on then to the board committee minutes, the first of which is the Audit Committee on the 14th of April. Rosemary, is there anything you'd like to add?
No, nothing I'd like to add.
Okay, any questions on the Audit Committee of the 14th of April? And then, thank you. Then we've got the Clinical Governance Committee of the 14th of April. Bruce, is there anything you'd like to add?
Nothing to add. Russell, any questions? Happy to take them.
Thank you. Any questions to Bruce on those committee minutes? And then we've got the NED F&P from the 6th of April. Simon, is there anything you'd like to add?
Nothing to add, Russell. Nothing to add.
Thank you, Simon. Any questions to Simon? So I think then on to any other business. Any other business, colleagues? Please raise a digital hand if you have any other business. Okay, then we've got, thank you, questions from governors and members of the public. Sarah, have we had any which we're aware of?
We have. We've had two from Roger Lloyd. So the first one is, what response has been received following the gold alert concerning paediatric mental health, and what actual action plan has been forthcoming, whether from the system partners, NHS Regional Office or NHS England? Now, Fiona Burton was going to answer that question, but she's obviously had to leave for another meeting. I don't know if there's anybody else that can answer it, or we could arrange a response to be sent to Roger outside the meeting.
Okay, well, we've reasonably comprehensively discussed the issue during the course of the meeting. So, Glenn, is there anything you want to add?
No, I was just going to say that, Russell. I think Fiona took us through the latest actions in the meeting for that reason.
No, super, thank you. And the second question from Roger.
Thank you. So the press, both print and online, has been suggesting that a significant number of qualified staff, whether doctors or nurses, are intending to resign or retire as the pressures and mental health strains of the last 2 years are beyond their capabilities. Is this just another urban myth, or is the trust finding the reality behind these statements? And Gert is going to answer this one. Thank you.
Thank you, Gertie. Thank you, Sarah.
Thank you, Chair. We've not seen any significant increase in turnover beyond what would have been expected. It is an area that we look at and we review regularly. Health and wellbeing and caring for our colleagues is one of our top priorities, and we have a vast range of wellbeing, particularly psychological support, that is on offer and available to colleagues. And you can see the decreasing rate of absence, particularly, although we know that stress is one of the highest reasons for absence and still is, that there's an improving position with regards to our colleagues and their view and feelings around work. So I can't comment on whether or not it's a myth, but it's not something we're experiencing, although we will keep an eye on it.
Thank you, Gertie. And are there any other questions from members of the public? If you want to raise a digital hand, now is your opportunity. Okay, I can't see any digital hands raised, so I'd just like to thank everyone and say we look forward to seeing you at the next board meeting, which is on the 7th of July. And for colleagues, I suggest we have a 5-minute stretch break and get into the confidential board at 3:20. In the meantime, thank you all very much.